So this is now really basic young EVRS. I just have one of my early complications. I want to show you, to discuss with you, maybe get some tips from you and giving tips to the younger ones to avoid that complication. So I'm going right into it. There was a redetachment, initial surgery 3 weeks earlier. I had a plan, there's a hole, drain it, and it would be easy, but it was a narrow pupil, so when I had the biome view intraoperatively, I noticed that it will not be that easy. Especially, you see, I saw a PVR's string which was lifting up the retina here, and especially it grew into the attached retina. It was almost like a tent, the retina here. So I made a new plan, which I couldn't peel it, so that's why I decided I want to clip it away. And you see, I have to go into the area where it's attached, and you can probably guess what was happening. So I made my line where I wanted to clip, and then clipping the detached part was easy, but the attached part, that happened. Unfortunately, Murphy's Law was a Saturday. My older consultant told me, you can do it tomorrow, when it was one of my first Saturdays on call, so I was there by myself. So what to do? IOP up, wait and drain. Shall I coagulate the bleeding, either with laser or endodiathermy? Shall I mechanically compress it, or are there any other ideas? I can tell you what I did. I put the IOP up, it stopped, I put it down, it came back. So that was not working because I was also afraid of the cornea. I do not want to lose sight. I ringed my consultant who decided with me to do that case, even though he fortunately answered. He said, just wait and drain the blood coming out. After 15 minutes, it stopped. So then I could continue the surgery. Those things, I wasn't brave enough by myself at that point of time. Any comments from the board? I see some experienced surgeons here. Parents, yeah, I was expecting that. Yes, thank you.
Retinectomy is good for everything. So if you want to avoid this not uncommon complication, is to use a little more endodiathermy power than we think is enough. It has two advantages. One, you reduce the risk of bleeding. The second is when you have a bleeding, because of the blood, you don't always know exactly the very location of the blood. With a higher power of the diathermy, if you approach the rough area of the bleeding, it will actually move the blood away. So you have a better view of exactly where it is. A second advantage in this case of having higher power is, again, that you may reduce the risk of PVR coming. I did not mention during my talk is I originally used this procedure for trauma, but I started to do it in eyes where I do a retinectomy along the line of the remaining retina, in eyes with giant tear, where you have a higher risk of PVR. I have not analyzed my data yet, but my feedback so far has been very positive. So the short answer is use a little bit of higher diathermy power than you normally would.
Any other ideas from the floor? So if I understood you right, you would do it prophylactically already with higher power on the attached. And if it's bleeding, you would do it also to stop the bleeding. So it works prophylactically and when it has happened. That is a good point, because the second question afterwards, it's better to avoid than to treat complications. What should I have done otherwise? Be more careful, of course. There's the retinectomy scissors. You saw I used the retractor where you can go, those who are not familiar with them, they're like this, so you can go under and then you can clip, and that would be an option. The technique, which I actually continued after the bleeding, which I call suck and cut. I turned off the clipping and just told it the retractor with maximum vacuum. I lifted up the flap, and when I caught some retina, I cut it and slowly approaching towards the point where I wanted. By manual surgery on the chandelier, picking up with a pick or with a forceps, and then cutting it carefully with the retractor, or any other suggestions from the audience or from the board. What is your, maybe somebody who has some idea?
I like to, I do the same thing when I'm making a retinectomy. I take the diathermy and make a single row, but in the areas where the vessels are very large, I'll burn an extra burn anterior and posterior along that vessel. And then when you're cutting with the retractor, just staying right in the middle of the area you've coagulated, I think helps. But I think the extra burn helps give you a little bit of leeway in case the cutter port slips a little bit.
I'm pretty sure my bleeding was choroidal, that I went into the choroidea, not into a retinal vessel. So I need more tips for doing a retinectomy on attached retina.
I agree with Christina in the area where you've got detached retina. In areas where you've got attached retina, I find it easier to use the scissors because you can actually use the tip of the scissor to lift the retina before you cut, and in that way avoid actually cutting into choroid. I don't know if the youngest member of our board has got any comments there.
Yeah, let me, as the youngest of all, tell you my thoughts about this, because the advantage of using scissors is that you have absolute control over where you cut. The risk of using scissors is that if you turn the scissors a little bit downwards, you will cut choroid. So you have a choice of, indeed, having a wider area of diathermy and then making sure that the retina is detached there, and then you can safely use scissors. But then the second disadvantage of scissors is time. You will spend a lot more time going and cutting. So I switched from that to a somewhat different technique. I reduced the flow. In other words, there is less risk of catching retina that you don't want to cut. I turn the port away from the remaining retina towards the peripheral retina, and then I slowly go along and not use scissors. But as with everything I say, this is my technique. It doesn't mean this is the best. This is one option to consider.
Seems to be that, as always, where there's a lot of options, not one is totally superior. When I look...
See, we've got just 2 comments from the floor. We've got maybe like a minute left. Dr. Mortada, you've got any questions or comments?
It's a comment. It's, how to avoid. I don't like to apply diathermy to the vessels. So as it was said before, so it is a line of heavy diathermy. And this heavy diathermy will make the retina frayed. So it is very friable and fragile. And where to cut, it is not in the middle of the coagulation, but anterior to the coagulation line, so that all the vessels posterior to the line of cutting are already coagulated. How to cut? I don't like to use scissors, but sometimes I do. But the way is you go with the cutter, you elevate the peripheral retina, and then you cut. Again, you go under the retina, you elevate, and then you cut. And this is, as I said, done anterior to the line of coagulation. When you reach to the periphery, you have to do indentation. Sometimes it's difficult to insinuate the probe with the indentation, but you have to relax the indentation again, elevate the retina, and then cut. And you have to have your diathermy ready so that once bleeding occurs, you ask the nurse to elevate the pressure and you apply diathermy, whether the bleeding is from the choroid or from the retinal vessels.
Thank you very much. We've got 10 seconds left for one last comment.
So the question, how to avoid this one? Basically, I would not go to the attached area and I will cut. Once I finish the detached area, I will go radially. So I will make relaxing radial retinectomy instead of going to the attached area. Thank you.
Thank you, but I felt I had because there was membranes on the 8H retina. We will stop here by thanking the EVIS board for giving us a chance to organize this session. We appreciate you all coming and taking part into the discussion. I hope you had at least as much fun as we. And finally, we of course ask everybody who sent in papers. We actually were lucky to choose. And by the most, thanks everybody who was participating. And for the protocol, we kept the time.